When I think about residual risk, I think about the modifiable residual risk because, of course, age and genetics and sex and things can't be changed, and they are a component of that ongoing risk. But if we look at the factors that can be altered in terms of further LDL lowering, in terms of antithrombotics, in terms of anti-clotting agents, in terms of hypertension, and in terms of further lipid management, particularly with regard to the other lipid profiles that give rise to risk, then we can begin to address modifiable residual risk with new ways, with new agents, and personalize it to people's needs. The LDL story has been a great success. Now we're looking at other lipoproteins. Our first port of call, of course, was to say, let's raise HDL. But the trials have told us that that does not result in a reduction in risk. The other ApoB-containing lipoproteins that are precursors to LDL are the VLDL remnants, chylomicrons and chylomicron remnants. And many of us believe it's the remnant populations, rich in ApoB, rich in cholesterol, that have a long residence time, that actually give rise to a good degree of residual risk in those individuals who have raised triglyceride levels. So I would focus on ApoB48 containing and ApoB100 containing remnant lipoproteins and their attendant cholesterol as markers of residual risk. The patient populations who are most likely to show high remnant levels are, of course, some people with rare dyslipidemias called remnant hyperlipidemia, but they're 1 in 10,000, 1 in 15,000. Most commonly, it's hypertriglyceridemics who have diabetes, or diabetes who have raised triglyceride levels, should I say, and other people who are obese, have got fatty liver, and that's a hidden marker, and the marker that you can see are raised triglyceride levels in these patients. So if you have a coronary patient with a triglyceride level above 1.5 or 150 milligrams per deciliter, you should then consider what the attendant risks are associated with that condition.